Hi, this is Michael Altos. We are continuing our discussion of neurophysiology. This is recording part 2. Now let's talk about the sensory nervous system. We have somatic neurons which collect information from all over the body. They can collect information that is mechanoreceptive, like tactile or position, vibration, thermoreceptive, that would be temperature, and in fact hot and cold are processed in somewhat different ways. Pain, which is nociception, and that would be due to some sort of tissue damage. And all of this is separate from what we call the special sensory neurons. Those are things like taste, smell, vision, hearing, and balance. Just a quick reminder that we have 3 different types of sensory nerve fibers. The biggest and the fastest are the A fibers, involved in motor, proprioception, and pressure. The exception are the A delta fibers, which are relatively smaller and slower, and they transmit pain and cold temperature. Then we have the medium-sized nerves, which are the preganglionic autonomic conduction fibers. And the smallest and the slowest are the pain fibers, which also transmit cold temperature and are also involved in postganglionic sympathetic transmission. These maps are relatively complicated and far beyond the scope of our physiology course, but I've put them here just for a very brief reference, and you are, of course, welcome to pursue them in more detail on your own. Your spinal cord has 2 main sensory pathways. The first is called the dorsal columns. If you think of the dorsal fin of a water animal, that's on the animal's back, and so dorsal is posteriorly. The dorsal columns transmit fine touch, position, and pressure, so indicated here by a feather. Sensory neurons enter the dorsal horn of the spinal cord. So if you look carefully, you can see that the spinal cord has sort of a butterfly shape on the inside of it, and those are the horns. The dorsal horns are posterior. So we have neurons entering the dorsal horn, ascending to the brainstem all the way up, and we see this is the lower medulla, so this is the brainstem. They synapse with a second-order neuron and then cross to the opposite side of the brain. So this serves as a first reminder to us that sensation on the right side of the body is processed in the left side of the brain, and that crossover occurs here in the lower brainstem. The other sensory pathway is called the anterolateral system. This is responsible for sensations like pain, temperature, crude touch, and itch, shown here by a candle causing tissue damage. These also enter the dorsal horn, but they immediately synapse and then cross over to a second-order neuron on the opposite side. And at that point, they're no longer posteriorly, they're no longer in the dorsal horn, they're in the anterolateral system. Then they ascend all the way up through the brainstem, the midbrain, and to the cortex. So we still see that sensation on the right side of the body is processed by the left side of the brain. But the difference is, instead of the crossover happening up in the brainstem, it happens down in the spinal cord at the level of entry. All of this information is ultimately processed in the brain. Here we see different sensory tracts coming up from the midbrain into the thalamus and then to the cortex. And different parts of the brain map to different parts of the body. In fact, they've drawn what's called a homunculus, which shows approximately the location and the amount of tissue that's devoted to processing from different parts of the body. So you can see things like hands and feet are sort of oversized because they have a lot of sensory. Of the face, we see the lips are especially sensitive, and each part of the body is mapped to a different part of the postcentral gyrus in the cortex. Now we should talk for a few moments about pain, which is one of the main focuses of our practice of anesthesia. Pain is a sensation that usually accompanies tissue damage. Some say there are 2 kinds of pain, fast pain and slow pain. Fast pain is felt very rapidly, within 1/10 of a second. It's often described as sharp, pricking, acute, or electric pain. And this is felt when the skin is pricked or cut or burned by some sort of mechanical or thermal injury. It is transmitted by A delta fibers. It's very easily located, so as soon as you feel it, you know exactly where on your body it came from, and probably involves the neurotransmitter glutamate. Slow pain takes longer to be felt, at least a second, often described as aching, burning, throbbing, or chronic. It's associated with tissue destruction, so we're talking more like chemical injury or chronic mechanical or thermal injury. It can occur in skin or pretty much any organ, and it's much harder to localize. It's sort of a general feeling of this region of my body rather than this exact point. It's transmitted by C fibers with the neurotransmitters glutamate and substance P. Pain receptors are free nerve endings that are found throughout the body, mostly in the skin. Other sensitive areas include the periosteum surrounding bones, the arterial walls, joint surfaces, parietal membranes. Those are the membranes that line the wall of a space, as opposed to visceral membranes, which line the organ inside the space. So just as a quick example, here is the peritoneal cavity. This is all visceral pleura surrounding the liver and the stomach. This is parietal pleura, which is the outer wall of the peritoneal cavity. And all of these different parts of the body can have free nerve endings to act as nociceptors or pain receptors. And they can be stimulated by any sort of mechanical, chemical, or thermal stimulus. So for example, ischemia probably causes chemical pain. Why? Because lactic acid builds up, and that, together with other chemicals, as a result of cell damage, stimulate the free nerve endings and transmit a sensation of pain. As the brain processes this pain, it has a built-in analgesia system, which we've discussed briefly before, that the brain is able to block incoming pain signals at the entry point to the spinal cord or at the level of the brainstem. And this can be accomplished through all sorts of different modulating techniques. One of them includes the presence of endogenous opiates. These are endorphins and enkephalins, which are very similar to morphine and those family of drugs, and they bind to opioid receptors in order to modulate and moderate the sensation of pain. We also talk about referred pain as sort of a third kind of pain. Referred pain is when you feel pain in a part of your body that is not close to the source of pain. Usually people feel cutaneous, they feel skin pain, not visceral organ pain. The reason is that the visceral pain fibers share neurons with skin pain fibers. So even though your gallbladder is having pain, since the pain fibers that feed the gallbladder also feed the right scapula, or rather the skin over the right scapula pain may be a manifestation of gallbladder injury. Other examples of referred pain include neck or shoulder pain when patients have coronary ischemia, or the famous ice cream headache, which is actually not due to pain in your head, but due to stimulation of the vagus and the trigeminal nerve in the throat and the palate. This figure on the right demonstrates some common sites of referred pain and the organ that's associated with it. Visceral pain occurs when injury leads to excitement of pain receptors across diffuse areas of an organ. So the viscera refers to an organ. This is organ pain. It tends to be crampy or aching. It can be referred pain, and it's usually felt in the midline. This happens when there's ischemia of any sort of visceral tissue leading to cellular damage, or let's say chemical damage like gastric perforation and acid leaks out and starts to digest visceral peritoneum. Or if a hollow viscus like the gut or the gallbladder or a ureter or fallopian tube gets distended or has spasm, all of these lead to this crampy, aching, visceral pain that tends to be pretty much in the midline. Parietal pain is sharp, localized pain. It hurts right over the area where the organ damage is. A good example of the difference between these two would be appendicitis. Early on, when there's inflammation in the appendix and it's being distended and there's infection there, patients tend to have pain right in the midline of their belly. As the appendicitis gets worse and there can be significant injury to that organ, the pain moves from the midline down towards the right lower quadrant, which is where the appendix is located. Hyperalgesia is the phenomenon of pain that is out of proportion to the intensity of the painful stimulus. And allodynia is having pain in response to a non-painful stimulus. So for example, if you stroke a person's arm, that shouldn't be painful. But if they have a sunburn, even stroking their arm can be painful, and that would be an example of allodynia. This has been a really brief overview of neuroanatomy and neurophysiology, but we should spend some time focusing on things that are directly pertinent to our practice of anesthesia. Let's spend a few minutes talking about evoked potentials. These are methods of monitoring neural pathways in order to avoid surgical injury to the nervous system. The ones that you're most likely to encounter include sensory evoked potentials, where we monitor the ascending sensory tracts, motor evoked potentials, where we monitor descending motor pathways, or electromyography, where we look at the electrical activity of nerves that innervate muscle. Sensory evoked potentials, as we said, monitor ascending sensory tracts. The most common by far is SSEP, somatosensory evoked potentials. But we can also look at sensory tracts that conduct the brainstem auditory pathways or the visual evoked potentials. The principle is to stimulate a sensory nerve peripherally and then observe the resulting EEG activity in the brain. We can look at the amplitude or size of the signal and the latency, the delay of the signal. SSEPs primarily monitor the dorsal columns. So they are used a lot in spinal surgery in order to detect ischemia or direct injury to the sensory tracts. We also use them in intracranial surgery to detect cerebral ischemia due to, let's say, too much retraction or compromised blood flow. In anesthesia, all volatile agents decrease amplitude and prolong latency, which means they sort of mimic injury. Of the IV agents, ketamine and etomidate will actually increase amplitude, so they will make it easier for the technician to see the signals. Other commonly used IV anesthetics, like propofol, ketamine, and opioids, are routinely used. And if volatile agent is used, we try to maintain it at less than half MAC. Any abrupt anesthetic changes or boluses will have an impact on the SSEPs, and so they should be avoided or else at least carefully communicated with the monitoring technicians. So just to be clear, what the technician is doing is either stimulating the patient's hands, feet, face, and so on with an electrical signal, or in the case of brainstem, they have a little speaker that they put in the patient's ear that makes clicks. And for visual, they actually have stickers they put over the patient's eyes that shine light. And then they look at the EEG response to those nerves transmitting sensory information. Motor evoked potentials monitor descending motor pathways. In this case, the motor cortex of the brain is stimulated, or potentially you could stimulate it in the spinal cord. And then you monitor potentials in the distal spinal cord or the peripheral nerves. You want to see a motor response. These are used in spinal surgery in order to assess integrity of the ventral or the anterior spinal cord. It turns out that from an anesthesia standpoint, motor evoked potentials are exquisitely sensitive to all volatile anesthetics, and you may very well be asked to use TIVA, total IV anesthesia, and avoid all inhalational anesthetics. Ketamine and etomidate are still preferred because they increase amplitude of the evoked potentials. And in addition, we have to avoid neuromuscular blocking agents because they will mimic injury in a motor tract. EMG monitors electrical activity of nerves that innervate muscle. The technician places needles into muscle in order to monitor muscle activity, and they can monitor spontaneous activity, or specific motor nerves can be stimulated and the muscle response can be observed. We frequently see EMG monitoring in the perioperative period for facial nerve and other motor cranial nerves during spine or neck surgery. Also during tethered spinal cord release, placement of pedicle screws during spine surgery. The main anesthesia limitation is that we cannot use neuromuscular blocking agents when EMG is being monitored. The last topic for this recording is spinal cord injury. When a patient suffers a spinal cord injury, if the injury is above the C3 to C5 area, they will no longer have control of their diaphragm and the patient will be ventilator dependent. Injury above C5 to C8, C5 to C8, will result in quadriplegia, loss of all four limb function. And injury above L1 to L4 will usually lead to paraplegia, loss of the function of the legs. In the case of an acute spinal cord injury, a patient will first have loss of sensation, flaccid paralysis, loss of spinal reflexes, urinary retention, bladder distension, loss of bowel control, and males may have priapism. The patient will go into spinal shock, leading to bradycardia and hypotension, and this may last for several weeks. Autonomic dysreflexia, which we will discuss in a moment, is possible, but usually uncommon at this early stage. Gradually, the patient will have return of their spinal reflexes and will experience muscle spasms and sympathetic overactivity. However, they will lose vasomotor temperature control, which means they will be unable to sweat below the level of the lesion of the spinal cord. Patients with chronic, long-standing spinal cord injuries will develop autonomic dysreflexia, also called autonomic hyperreflexia, if the spinal cord injury is above T6, and this usually appears within the first year after the injury. What does this mean? Any sort of cutaneous or visceral stimulation below the level of the spinal cord injury will lead to exaggerated autonomic reflexes. Examples of stimuli include bladder distension, a urinary tract infection, constipation, sexual activity, labor and delivery, lower extremity infection or injury, and any sort of surgical procedure below the T6 level. With autonomic dysreflexia, symptoms include headache, diaphoresis, and very pronounced hypertension. Bradycardia is common, although some patients will have tachycardia instead. You may also see other autonomic signs, including flushing, piloerection, blurred vision, nasal obstruction, anxiety, and nausea. These patients are at high risk for cardiac arrest, intracranial hemorrhage, and seizures. Autonomic dysreflexia in the operating room can be prevented with either general or regional anesthesia. And if a patient is experiencing autonomic dysreflexia, the treatment is to put them in an upright position, remove the noxious stimulus, and medications to reduce blood pressure. Remember that patients with chronic spinal cord injury have lost their vasomotor temperature control, which means they cannot sweat below the level of the lesion. But their chronic vasodilation can lead to hypothermia. Also remember that a spinal cord injury leads to a risk of hyperkalemia due to the increased number of acetylcholine receptors outside the neuromuscular junction. And therefore, succinylcholine should not be used in these patients without careful consideration of the risks and benefits. That's the end of this section. Please let me know if you have questions about any of the points. We'll have immediate loss of sensation in all of the nerve roots below the level of the injury. They'll have flaccid paralysis, no muscle tone. They'll lose spinal reflexes. And this is called spinal shock, and it lasts for about 1 to 3 weeks. Gradually, the spinal reflexes will start to return. The patient will have muscle spasms and a lot of sympathetic overactivity coming from this injured spinal cord. The phenomenon of autonomic hyperreflexia occurs when there's any sort of cutaneous or visceral stimulation below the level of the spinal cord injury, and this leads to an exaggerated autonomic reflex. Patients will have vascular hypertension below the level of the spinal cord injury, and vasodilation or bradycardia above the level of the spinal cord injury. As we move from acute to the more chronic phase of spinal cord injury, we should always expect patients to have autonomic hyperreflexia if they have a spinal cord injury above about T6. So this means that we have to provide anesthesia for spinal cord injury patients, even if the surgery will be occurring in a part of their body that no longer has function. For example, foot or ankle or lower extremity surgery in a paraplegic patient. Another example could be something as simple as cystoscopy in a patient who's even paraplegic. You might think that the bladder distension from cystoscopy is uncomfortable but not painful, but in fact, going back, or actually we can just stay here, because of this hyperreflexia, they can have a pronounced and life-threatening change in vital signs if you do not anesthetize them, either with general or regional anesthesia. Because of the chronic vasodilation that occurs in spinal cord injury patients, they may become hypothermic. They are also at risk of hyperkalemia because of their increased number of acetylcholine receptors, even outside the neuromuscular junction. And that's why we learned that succinylcholine should not be given to patients after about 4 days into a spinal cord injury. We will stop here, and please let me know if you have any questions.